Thank you all for listening to our podcast today. This is the Osteoscience Foundation's Generations of Regeneration podcast interview series. And we are fortunate today to have with us Dr. Eric Carlson, who is a mentor of mine and who was also my fellowship director in Tennessee. As a brief introduction to myself, my name is Thomas Schlieve. I'm an oral and maxillofacial surgeon practicing at Parkland Hospital in Dallas, Texas, also out of UT Southwestern Medical Center. I'm an associate professor there. I've been program director now for 6 years, and I've been at Parkland for 8 years. That was immediately following my fellowship in maxillofacial oncology and reconstructive surgery with Dr. Eric Carlson at the University of Tennessee Cancer Center. Interesting, I did medical school after I finished my residency. So I went to medical school at LSU Shreveport, where I had the privilege to work with Dr. Gali while I was there. I did a year of general surgery following my medical school training back at the University of Illinois, Chicago, which is where I completed my oral and maxillofacial surgery residency under the guidance of Dr. Michael Maloro and Dr. Tony Kolakidis. And prior to that, I was a dental student at Marquette University Dental School in Wisconsin, where I was born and raised. As I mentioned, our invited guest today is Dr. Eric Carlson. He's currently a professor and chair of oral and maxillofacial surgery at the University of Tennessee Medical Center. He has, as you all know, written many textbooks, including the most, what I would say, well-known and circulated text on salivary gland pathology. He has hundreds of peer-reviewed publications and has delivered numerous lectures around the world. I'll let Dr. Carlson make a brief introduction for himself and talk to you a little bit about his background.
Thank you, Dr. Schlieve. I really appreciate your kind comments and the opportunity to spend this time with you. I've very much looked forward to this dialogue that we'll have. I originally hail from Newton, Massachusetts, outside of the Boston area. Received my undergraduate degree from Connecticut College in biochemistry. I then went to dental school at the University of Pennsylvania. Thereafter, I completed my oral and maxillofacial surgery residency at Allegheny General Hospital in Pittsburgh under the mentorship of Dr. Guy Catone. From there, I headed to the University of Miami, where I met an extremely important person in my life, Dr. Robert Marks, who gave me my training in benign and malignant tumor surgery and reconstructive surgery. I then found myself in Detroit, Michigan for my first academic position at Henry Ford Hospital. I was there for about 3.5 years, and Dr. Marks lured me back to the University of Miami for a faculty position that I held for 9 years. I traveled to Knoxville, Tennessee 22 years ago to be chairman of this department. I was the residency program director for the first 17 years I was here, and that followed being the residency program director at the University of Miami for 3 years. And while coming to Tennessee, I had a medical degree that I received from the University of Miami. About halfway through my faculty position, I took a couple of years off to obtain my MD. So when I came to Tennessee, I had a degree, but I didn't have a license to practice medicine. And so I did a second year of general surgery early on during my experience here. So in 2003, I was a second-year resident in general surgery. I was chairing the Department of Oral and Maxillofacial Surgery, running the residency program, trying to get a 6-year program started here for our residents. And I was beginning to develop the fellowship program in oral and head and neck oncologic surgery. On July 1st of this year, I started my 35th year of academic practice. It seems like yesterday that I started. Lots of great stuff has happened along the way. I've taken 2 breaks, one to obtain my medical degree and another to obtain my master's degree in education, which I received from Harvard University in 2018. So like your career, Tom, lots of exciting things have happened, and I look forward to elaborating on some of those things here with you.
Yeah, that would be great. I think both of us share that background of medical training after residency, and we'll get into that in a little bit. Why you did that, why I did that, and I guess why we think it's important. Before I start formally interviewing you, just to kind of bring things back a little bit, Dr. Carlson for me is someone who is a mentor and a role model, and really has been since the first time I talked to him on the phone about coming to Tennessee for fellowship. I consider him a friend of mine. He's been someone who at every step of my career has truly been a mentor for me. And as part of this discussion, hopefully we'll kind of touch a little bit more on mentorship. And it's something that when I talk to residents who are going to fellowships or just residents who are looking for jobs, you look for someone like Dr. Carlson, someone who is going to kind of guide you in your career. And so much of my success I really owe to you, Dr. Carlson, and very appreciative for everything you've done for me, helped me, and taught me.
Okay.
All right, to the formal interview questions. So I think a great place to start would be, what set you on the path to oral and maxillofacial surgery? What is it that led to your decision to be an oral and maxillofacial surgeon?
Yeah, that's a great question, Dr. Schlieve. So, like so many people who are passionate about their career, there are defining moments in that individual's education that pointed one in the direction that he or she has realized. For me, my interest in oral and maxillofacial surgery began when I was a dental student at the University of Pennsylvania. And it was long before I ever heard a member of our specialty utter a word about what they do. It actually started in first year anatomy. I became absolutely fascinated with not just head and neck anatomy, but with all of human anatomy. And my teacher was Dr. Joseph Ashman, who was a remarkable teacher and was able to convey difficult concepts with ease. And I think Dr. Ashman taught us a very difficult topic that typically people memorize. But the way he taught it was for us to learn. It was the first time I experienced a deep learning environment when I was a dental student. So Dr. Ashman was the first person who impressed upon me what would become a future career in surgery. And after all, surgery, as we know, is really an exercise in anatomy, in the dissection of anatomy. The second person who really provided the impetus for me to become an oral and maxillofacial surgeon, and interestingly, to subspecialize in benign and malignant tumor surgery, was an oral pathologist by the name of Dr. Edward Lally. Dr. Lally was also an exceptional teacher. I was fascinated by the pathology that he taught us. In the second year curriculum at the University of Pennsylvania, it was general pathology. In the third year of that curriculum, he taught us oral pathology. But just as I was fascinated with whole body anatomy under the direction of Dr. Ashman, I was also fascinated by the general pathology curriculum that Dr. Lally took part in. So these are the 2 individuals who really inspired me in a career in surgery, and quite frankly, who made me fascinated with systemic pathology that ultimately set the stage for my obtaining my medical degree. Residency was a reinforcement of all of these great things, but it was really my fellowship that was the next great stimulating element in my career. And Dr. Marks not only made me fascinated with benign and malignant pathology and the surgery to correct those diagnoses, but also in teaching. He was another teacher who was just tremendous in getting complex points across. Like you, Dr. Schlieve, I'm sure that I am asked many, many times by residents, how many of these procedures do I need to do in order to be competent? And as you know, I always answer complex questions with the answer, it depends. And I elaborate by indicating it depends on who's teaching you. One of the outstanding characteristics of Dr. Marks as a teacher was that he was so good that I felt that when he explained something to me, I really had a deep understanding of a complex issue. But also, when he demonstrated a surgical procedure for me, I felt competent at an early time frame. And so the depends means that if you're taught by a consummate teacher, both clinically and didactically, you probably don't have to do as many of those procedures to be competent and entrustable as if someone else is teaching you, for example.
Yeah, I could not agree with you more, Dr. Carlson. I think the teacher plays a big role in the student's development, and we have all had experiences with different faculty, and I think residents recognize it. We recognize it in our own career. There are those individuals who you've operated with, who you've learned from, where it's easy to learn,
Right.
and you walk away from the surgery feeling like you could do this.
Right.
And sometimes you walk away almost more confused than you went in it, uh, depending on how things go. So it is always interesting, and for myself in my background, it was really pinnacle moments that set me on my path. Especially to fellowship and to medical school. When I went to residency, I had no inclinations for academics when I started. I just didn't have that correct role model. I didn't have the right person.
No.
And then once I met and worked with Dr. Maloro and Dr. Kolakidis, who are career academicians, there was no other option for me at that point. I knew what was next, and I knew I had to go to medical school if I was going to make those things happen in the right way, learn what I wanted to, and then move on to fellowship.
Right. And your mentors, like mine, really define the triple threat academician. These are people who really find the time to do it all. They're tremendous clinicians, they're great researchers, they're real scholars who have contributed to the international literature. And most of all, and most importantly, they represent an incredible inspiration to people like you and me, and we're grateful for them. I'll share with you one aside note. When Dr. Lally passed away in 2019 after a real storied career at the University of Pennsylvania, his family contacted me and asked me to serve as one individual providing a eulogy for Dr. Lally. It was an incredible honor. It was one of those moments where you just stop, you kind of freeze in time, and you feel that chill up and down your spine because that person inspired you so much that you want to give back. And being able to speak a few words to a large group of people, his family, his friends, and colleagues, was an incredible honor. I'll never forget how I felt when I was contacted by his son, who I saw grow up. And
Yeah.
Dr. Lally and I became good friends, and so I knew his kids growing up, and it was one of his kids who's a radiation oncologist now, who actually contacted me and asked me to provide a eulogy, which I immediately agreed to, and it was an incredible experience. So
Yeah, that's a special moment and speaks to the connection that you make with those few influential individuals
mm,
that cross our lives.
yeah,
Um, so you mentioned earlier your decision to go to medical school in 1997 after already having completed residency, already being on an oral surgery faculty. You're there. You have a real job now. You're making money. I mean, what was it that convinced you medical school was the right thing to do at that point in your career?
right. So the aforementioned individuals, Doctors Ashman and Lally, convinced me that at some point in my career I would go to medical school. I just didn't know when it would be. So the question wasn't if, it was when. And upon completing dental school at the University of Pennsylvania and heading to residency, which was a single degree residency, I was ingrained in a very specific culture, a single degree culture, and I really didn't think a whole lot about anything else. At that time, there were two programs in the United States, the University of Nebraska and Mass General Hospital, associated with Harvard in Boston, that offered a dual degree curriculum. So in residency, I would say that my interest wasn't really cultivated because we were a distinct single degree program. In fellowship, I think the same thing was true. Dr. Marks was a steadfast believer that the single degree tract was appropriate and satisfactory to create success in one's career. And I believed that at the time, but times change. And here's how it happened for me. So my first faculty deployment from 1990 to 93 at Henry Ford Hospital in Detroit, again, we were a single degree program. We didn't have a dual degree culture, so we didn't talk a whole lot about it. Even though in 1992, the AAOMS put forth a recommendation that all programs in the United States consider a dual degree track. Well, in November of 1993, I took my second faculty position, this one at the University of Miami, which was a dual degree program. And so I would see residents, I was training residents who, quite frankly, knew more about clinical medicine than I did. This was the first time that I adopted a real vulnerable state in terms of who I was and what I had to offer. And I felt partial and incomplete. I would see the residents in the Miami program go away, they would blossom, they would come back and be able to extemporaneously talk about Addison's disease for 20 minutes without notes. And not only did I admire that, I was envious of it. And I decided I needed to do something about it. I felt like I was practicing our subspecialty at a pretty high level. I had a lot of support by Dr. Marks as my boss at the University of Miami, along with the late and great Dr. Stuart Klein and other faculty in that program. But I really felt like I was holding myself out to my patients in a very specific way. I was holding myself out to other medical professionals in that academic medical center. And I almost felt like I had imposter syndrome. We're starting to talk a little bit about that. I felt very uncomfortable. I really wanted to be able to walk the walk as well as talk the talk. And so in the spring of 1997, I made a proposal for a 2-year leave of absence to obtain my medical degree right there at the University of Miami. And it was an amazing experience. Of all the things that I've done educationally in my career, this is one that I would do all over. In that vulnerable state as a student for a little bit over 2 years, I had a few revelations. One is I didn't know nearly as much as I thought I did. Two was I recognized that the best surgeons are internists who perform operations. I recognized that I was taking care of the whole patient. I wasn't just performing surgery, but I was providing perioperative care for their medical comorbidity. And until I had that bona fide medical training, I really wasn't sufficiently qualified to do that. That said, I'll share with you the third revelation that I had, and that is that my second year of general surgery really put it all together for me. It permitted me really to practice medicine and to take that deep learning experience from medical school and really put it to work. Every day since completing medical school in May of 2000, and every day since completing my second year of general surgery at the end of the calendar year in 2003, I've been able to do exactly those things. And it feels a little bit better to me. I guess the fourth revelation that I'll share with you is that dental education really taught me how to memorize. Medical education taught me how to think. And I'm grateful for that. Now, Dr. Schlieve, you and I know that this remains a controversial issue in terms of how best to educate an oral and maxillofacial surgery resident, and it always will be. This podcast will not solve that controversy or dilemma. When I came to Tennessee, the oral and maxillofacial surgery residency program had been in existence for 50 years. It started here in 1952. I embrace the value of the four-year program that we have here. In 2013, I obtained final approval to initiate the six-year program in our residency. And so here in our academic medical center, we have both programs running simultaneously, and I think it's a great experience. As an educator, it's great for me to be able to observe the dynamic between the four-year residents and the six-year residents. I also have some residents in my program, two currently who are MD first, DMD second. And I've trained now, or I'm in the process of training three of these. The first two who I trained actually did their year of general surgery after obtaining their medical degree before they went to dental school. And so I guess I make those comments just to offer the steadfast opinion that there are a lot of ways to train an oral and maxillofacial surgery resident. And I think flexibility on our part as educators is absolutely essential to make those revelations.
Very, very good. I was going to ask you as in talking, you talked about the value of that medical degree and how it changed how you thought about things and the revelations you had. Do you think that doing medical school when you did it contributed to the benefit that you received from it? And part of that, I ask the question only because of my own experience doing it after residency.
Right.
I almost knew more what I was missing and what I really wanted to then get out of that medical education. And, you know, here at Parkland, we only have a 6-year program, so I don't get to see that dynamic of the 6-year who comes back, but the 4 years are still there. And maybe you could comment on two things. One is, do you think you got more out of medical school because of the timing and how you did it? And then two, what differences do you notice among your residents who do the two different tracks? How does that work in the program?
Yeah, these are great questions. So when I went to medical school in 1997 at the University of Miami, I was 38 years of age. I had 7 years of practice, as you mentioned earlier. I had completed residency, I'd completed fellowship, I was in practice for 7 years. I was happy with my career, although there was something missing, which became very clear to me. But I think there's a degree of intellectual maturity that exists in someone who's had that education and been in practice for that period of time. The great understanding for me in going through that process, since I did the entire second year, the entire third year of medical school, and about 4 months of the fourth year, was that my background, including a degree in biochemistry, an undergraduate degree, didn't really help me in the didactic component of medical school. It wasn't until I really got to the clinical rotations in the third and fourth year that my background really provided assistance. I always like to share with people that when I graduated dental school in 1985, the cytokines hadn't yet been mentioned, hadn't been really discovered. So when I got to medical school 12 years later and we started talking about cytokines and the like, this was all new to me.
Yeah. Yeah.
The molecular biology of cancer was something completely new, and I'd kept up with it because that was my career. But it was at somewhat of a superficial level until I got to medical school, and we really took a deep dive into all of that molecular biology. Of course, in pharmacology, the drugs change frequently, and so I was learning new classifications of medications. So it was a steep learning curve for me, but I did have the ability and the wherewithal to know how to study. I felt because of my age that I had a better sense of what was important and what wasn't in terms of studying for exams. And I also had pretty good time management skills that permitted me to start studying for the USMLE Step 1 about, 9, 10 months in advance and not wait
Mhm.
until 6 weeks before that exam, which you know very well was
Yeah.
a real rite of passage. And
Yep.
so your second question is a very good one in terms of looking at the 4-year and 6-year folks kind of side by side. And I also saw this in Miami as the program director for the last 3 years I was there. We had both tracks going on simultaneously. And my observations back in the late 1990s, so about 25 years ago, were that our single degree surgeons were very good technically. Our 6-year residents just had a wealth of medical knowledge. When you put them together, you have the perfect resident. But there is no such thing as a perfect resident. So as an educator, now for 34 years, in my 35th year, I try to think about how to meld those two advantages into one resident. And as you well know, as a residency program director, it's very difficult. But our specialty is very diverse. And so I'm not sure we have to produce that perfect person. Because here, by and large, our single degree graduates enter private practices in the community, either locally or somewhere closer to their home. And they're very successful in terms of administering office anesthesia and providing office-based minor surgical procedures. Many of them take trauma call and provide those great services. What I'm starting to see here now, since we just graduated our 5th dual degree resident last month, is that quite a few of these are entering fellowships. One who's now on my faculty, did an oncologic surgery and microvascular surgery fellowship. Of our graduates last year, one went into pediatric and craniofacial surgery, another went into a clinical investigation fellowship. This year's graduates, one has matched for an oncologic surgery fellowship, and the other is currently in a pediatric and craniofacial surgery fellowship. So we're seeing all sorts of different career trajectories, and it's very exciting to me to see where people head. And I like to think as their faculty that we're a big part of inspiring them, just as you and I were inspired by our mentors earlier on in our careers.
Yeah, that is definitely something I hope for all of my residents, and something that you kind of touched on, this resident education, how we teach residents. I know, you've put some very dedicated, focused effort into learning more about how to teach the current generation of residents. So along those lines, maybe you could tell us what prompted you to go seek out your master's in education, and then I guess subsequent to that, I mean, how has your approach to resident education changed? You've been at it for 35 years.
Yeah.
What I've been at it for 8.
Mhm.
What has changed during that time?
Yeah. Yeah, great. So, just as I mentioned, I had a pivotal point in my career in early 1997 when a very vulnerable state made me realize that I was partial and incomplete, and then went to medical school. I had a second vulnerable state of feeling partial and incomplete on a Sunday afternoon in April of 2015. I remember exactly where I was, what I was doing, and I realized that at that point, after nearly 25 years of academic practice, um, residency, fellowship, medical school, general surgery, a career dedicated to teaching the next generation of resident and fellow in our specialty and subspecialty, that the thing that I really loved about my career was teaching. And sadly, I recognized that I had absolutely no background whatsoever in adult learning theory, in academic leadership, in innovation in teaching, an assessment of teaching and teacher quality, and the list went on and on. And I decided I needed to do something about it, and I needed to create a plan to obtain a master's degree in education. And so I went down that journey. I found one school that had a very intense, fast-paced residential program in as a master's degree in education. It was at Harvard University. Um, and I'm from the Boston area. My dad at the time was living about 10 miles from the Harvard campus. I thought that this was an amazing opportunity to correct a problem that I had identified. And so I took the GRE. And at my age at the time, in 2000, late 2015, I think people my age and at my stage in their careers were thinking about things other than taking the GRE. But I took a Kaplan course, which is an amazing educational platform with their teaching style, their interactive teaching style, and in terms of their practice questions and the materials that they supply to you, just amazing. And I knew that to get into my school of choice, the Harvard Graduate School of Education, I had to have a very competitive score on that GRE. There were 3 sections of it. One was writing, that went very well. One was quantitative analysis, so math. I was relearning high school algebra and geometry. And the other was qualitative analysis. It was reading comprehension and vocabulary. I think I memorized 1,000 new vocabulary words for that test.
I remember that.
I've forgotten 980 of them, but I learned them long enough and took the exam in November of 2015, and it went quite well. And up until that point, I never thought that a university like Harvard would ever consider me. But I applied, and I remember the first Friday in March of 2017. So I applied in the fall of 2016. That was my next available cycle. I took the GRE in November of 15, applied in the next available cycle, which was a deadline of September of 16, and I got my acceptance electronically the first Friday in March of 2017. And I remember how I felt when I opened up that email and I saw that I was accepted for something that I'd been thinking about for 2 years, actually.
Mhm.
I then asked my dean for a formal sabbatical, a 1-year sabbatical. It was granted by the chancellor of the University of Tennessee Health Science Center, and off I went in July of 2017. I had a deliberate strategy that was clear to me, and that was just to be a better teacher, to just understand all the things that I shared with you a moment ago. Adult learning theory. How do adult learners learn? And I had no idea, but I took a real dive into it, and I have a better appreciation for that now. What is academic leadership? How is it that you and I, in leadership positions, for example, how do we exist in our academic medical centers? How are we impactful? How do you and I, Dr. Schlieve, impact um, Parkland and the University of Tennessee Medical Center, respectively? Um, how do we grow existing programs and create new ones? These are the sorts of things I wanted to understand. How do I assess teaching in my faculty? What is risk taking and why is that important to education? And finally, innovation. Those are my deliberate strategies. The emergent strategy, the thing that ended up in my lap that I did not anticipate, that in studying all of those things and in taking the thesis tract as part of a qualitative research study, I was creating a construct for faculty development. And it sort of came to me one day, you know what? All these things are just creating a platform, a construct in how to provide professional development for faculty in oral and maxillofacial surgery programs, including yours and mine. And so when I graduated and I came back here in the summer of 2018, it was with the expressed purpose of introducing that platform that I learned to this academic medical center and to contributing to the literature. I'll share with you, as my father said, my dad passed away at the age of 98 about 2.5 months ago on August 25, 2024. My dad was my hero in my life, unquestionably, the person who is responsible for all of the success, really, that I enjoy to this day. But he always said something brilliant. He said a lot of really brilliant things in his 98 years. One of them was that when you finish a degree granting program, it's called commencement for a reason. And that's because it's not over, it's just beginning. And so I would say that I have learned probably more about education and faculty development since I completed my program at Harvard in the summer of 2018. And I've attempted to bring that back here and to be a better teacher to my residents, to be a better mentor to my faculty, and to be more impactful overall in the academic mission of the University of Tennessee Medical Center.
Have you been asked, or have you worked with, I guess, the dean of the medical center, or gotten involved with faculty development outside of oral surgery at the University of Tennessee?
Yeah, so yes to both, really. And when I came back, my dean, who approved my sabbatical and was really excited about it, he was the consummate teacher and administrator. He made me the co-chair of the Academic Leadership Academy here that was developing at that time. We're in our fourth year now. We took about a year. The chair of family medicine and I were appointed co-directors, and we spent a fair amount of time creating a 1-year program that we administer to 10 faculty in the medical center on an academic year basis. And so that's been very exciting. And that is a year-long program. We have quarterly 5-hour sessions on Saturdays. and we have 2-hour sessions monthly on Tuesday evenings. And it's a great exchange of ideas. I give a number of lectures in that I provide coaching to those faculty who are interested in the coaching program that I learned called Immunity to Change. And I've also had the opportunity not only to publish on faculty development concepts in the Journal of Oral and Maxillofacial Surgery and the clinics, for example, but I've had invitations around the country to provide faculty development programs at dental schools and medical schools and other academic centers around the country. So it's been very inspiring and uplifting to me to be able to provide these programs locally and outside of Knoxville.
Yeah. It sounds like quite a commitment, and maybe I'm jumping around a little bit on questions here, but it makes me think of, questions that maybe residents have for us sometimes. I mean, sort of, how do you do it all? I mean, you're a chair, you're a fellowship director, you have a very busy clinical practice, you're writing, you're researching, you're leading academic development. I mean, how do you allocate your time between all of these different endeavors? And something we've talked about before, how do you avoid the word that they put, burnout? How do you
Right.
not burn out? How have you done this for 35 years and you're still as excited about it today as you were the first day?
Yeah, so I think it goes back to your first question, and that's mentorship during that academic journey, and meeting people who are very inspiring to me. Um, I guess I would answer your question, Dr. Schlieve, by sharing with you my leadership style, which is there's no beginning or end to the workday or work week. And that I feel very lucky because of the inspiration that I received and all of the support that this is a labor of love. As you well know, I'm speaking these words to somebody who understands exactly what I'm talking about. I think it's easy to utter the word no, and so I don't. Um, and it becomes challenging, but it is a labor of love. So let's talk about burnout here just for a moment because you raised
Mm-hmm.
the topic. I read on the weekend, and I printed this today because I thought this topic might come up. So this is the AMA newsletter that we receive electronically on a Saturday, and this week, the electronic newsletter of the AMA indicated in 2023, 48.2% of physicians reported experiencing at least one symptom of burnout, a la the Maslach triad of depersonalization, emotional exhaustion, and the perception of not being appreciated. And that this incidence of 48.2% in 2023 was down from 53% in 2022. What's interesting is that the overall rate of burnout amongst physicians shortly after COVID was a whopping 62%. And I think you and I both saw that in some of our colleagues in our academic medical centers. So anytime we talk about burnout, we have to talk about two other things, and they are wellness and life-work balance. So I'll start with wellness. It's clear to me that wellness is not a one-size-fits-all concept. Not at all. For some, wellness means taking their 4 weeks of vacation annually that's allotted to them, their paid time off, and going to some very exciting place. To others, it's renting a Ferrari or a Lamborghini on their birthday every year and driving it for a weekend.
Yep.
To others, it's on, such as me, on Saturday and Sunday afternoons, I have a gym in my house, And my wife and I built this about, 10, 12 years ago, and we use it on a regular basis because when I get home, I don't have time to put on my gym shorts and go down the street to a gym. So we have one in our house, and we use it quite often. And I do a lot of exercise on the weekends, and that creates an endorphin rush that is just second to none. My wellness is also spending time with my family, a good meal with my family. I don't take a lot of vacation because I travel to some very nice places when I'm invited to speak at meetings. I have a spiritual side to me that provides wellness. And so my wellness package might be a little bit different than others. I'll also share with you that my life work balance portfolio is probably very different from others. I'll give you an example of that. After a 12 or 13-hour day on a Friday, and you saw this firsthand, and I know you do this as well, I get up at 4:30 on Saturday mornings, and I love coming in here. And that's just the way it is. It sounds counterintuitive, but part of my wellness package is my career. It's in spending time with my residents from whom I learn and enjoy that time. And so I guess I would share with you that that type of life work balance doesn't necessarily lend itself to burnout. And I'm not burnout, and I don't ever anticipate being burnout. And I'm inspired by everything that I'm able to do professionally, and I have a good personal life. And so that to me is wellness. And I don't apologize to anyone for it.
Yeah.
So
Yeah.
that's
No,
it.
no, no, nor should you. I mean, I like that you did say that wellness is different for each person, what wellness means, because I think sometimes when wellness is talked about, it's almost like, here's wellness and here it is for everyone.
Yeah,
And we're not all the same individuals. We have different motivations, different
yeah,
things keep us going. And I am very much like yourself. I mean, being with the residents, teaching the residents
yeah,
is a pleasure. It's fun. It's exciting for me. I mean, that's part of my wellness is
yeah,
the fact that I get to teach,
yeah,
uh, and maybe that we truly enjoy or love what we do
yeah.
in our careers, and
And also the
maybe
people we do it with,
right. And I
and
don't know. I guess the question: do you think you surrounded yourself with those people, or you maybe you have challenges early on, but you built a structure over the years that kind of contributes to your wellness.
yeah, I think that's a very good question. We speak a lot about hierarchy in academic medical centers and in residency programs and the like. And I with intentionality in 1990 on July 1st, when I stepped foot for the first time in an academic medical center as a faculty member, that one in Detroit at Henry Ford Hospital, I adopted a non-hierarchical approach to resident education. Um, you can flatten the pyramid, so to speak, but not eliminate respect. In other words, you can befriend residents and be emotionally intelligent with them, but not to a fault. They won't abuse that as long as you earn the respect that you require while also breaking down hierarchy. It's interesting. I thought that in 1990 in July, 34 years ago, and it has become an essential part I think over maybe the last 5, 10 years or so. This is one of the things I learned in graduate school. It's become an essential part of existence in residency programs. The current generation that we're teaching, you referred to this earlier, really requires a non-hierarchical approach to education. We need to have an open door policy. We need to be able to provide micro mentoring for them. In other words, rather than insisting that they learn from us through 1 hour PowerPoint presentations in a stuffy lecture hall with the lights off. We need to be able to do that, but also to provide, little 5-10 minute conversations that will provide the education to them that they truly require. And this is one of the reasons why you're very successful in your role as the program director at Parkland, because I see this in you and knowing you well, and it's something I try to do as well. So the old days when you couldn't walk in your chairman's office unannounced are long gone. The door is wide open, literally and figuratively. I think that benefits patient safety. I think that benefits resident education. I think it produces the co-regulated learning that we require in our residency programs, in our fellowship programs.
And I think too, it is, for me, it's more enjoyable in that fashion rather than doing 1 hour lectures,
Right.
rather than almost leading through fear that I'm at the top. You don't talk to me. The interns go through the second year, who goes through the third year, who goes, and maybe the chief then can talk to me. That's just not who I am.
Right.
But also,
very true.
I think it's more enjoyable to have a more collegial relationship with your residents. And yes, there's a mutual respect that they have, and definitely you earn that respect, and it's showing up. I mean, you have a long case, like you said, on Friday, and you're there on Saturday.
Yeah.
Without question.
Yeah.
And they see that, and they know how hard you work and the effort you put in, and they respect that.
Right. And I think that I agree with you. I think they appreciate it as well, because in that co-regulated learning environment, there has to be the ability to bounce questions off the faculty. And if you're here, then that's an easy task.
Yeah.
One of the things that you and I both know is the 3 A's of success. So ability, affability, and availability. The availability is so important in this current generation. Our non-hierarchical approach to resident education, and just our literal FaceTime permits a much better educational process. And plus, it's exciting to me, just as I communicate with those teachers in my residency program and fellowship program on a regular basis. It didn't end at the completion of those programs. So too is the case with our residents and fellows who complete their programs. They still reach out to us. They share their first great case with us, and you and I both know that our lives are very rich because of the personal and professional relationships that we've made along the way. And it'll always be that way, and that's very exciting.
Yeah, I definitely, that's something I very much appreciate in my career and with my residents. I enjoy getting that text or call about the first whatever it is that they've done. Usually it's like a submandibular gland excision that they're really excited about, because it's something that gets me excited to teach them that type of case. But all right, so then our residents do leave us. They go on and they hopefully do great things and make us proud, and that then maybe brings us to a short discussion about mentorship and the importance of having mentors in your career. So I would ask you, what do you think the importance is of a mentor? And how has your relationship with different mentors changed throughout your career?
Yeah, that's a great question. I think that that mentors represent exceptional role models. And I think that everybody who you and I know who is successful will quickly point to somebody with a smile on their face who inspired them and gut them down the proper path. I think those mentors encourage us to have careers, not jobs. Jobs are where you look forward to going home at night and look forward to going home on Friday evening and not coming back in until Monday. Jobs are where, when you're on call, you look forward to an easy call night. Careers, by contrast, are where you love being where you are. You know, and you're in no rush to go home at night, and you look forward to coming in the next day, and you spend time in your workplace, even when you don't need to, because it represents your identity. So it's the definition of a mentor is someone who role modeled that extremely well for you. I have a very good friend who's a good friend of the specialty who refers to me as a hospital rat. He says that at certain times during the day and week, there aren't many living creatures in this hospital except the rats in the basement and me somewhere else in the hospital. So, you know, I appreciate that, and I consider that a great compliment. So you and I both know that our hard work is beneficial, certainly to our academic departments, certainly to the academic arm of those academic departments, but it's also very beneficial to our specialty nationally and probably internationally. Because when people see you do something really good, Dr. Schlieve, they associate that with oral and maxillofacial surgery. And maybe they see you do something that hasn't been done because of your unique training and background that hasn't been done previously by an oral and maxillofacial surgeon in your university hospital and outlying hospitals. And so that hard work is just so beneficial to the national organization that has provided us tremendous support in our careers. So, you know, that hard work really goes a long way. And everybody and everything benefits by it tremendously. So I think our mentors really showed that to us exceptionally well. I know mine did. Guy Catone in Pittsburgh and Robert Marks in Miami. You know, these are people who just went the extra mile at all times to defend the specialty, promote the specialty, educate their trainees, support them long after they were gone. I'll share with you an interesting story. So when I was in Boston for that year, obtaining my master's degree in education, my residency chair, Dr. Guy Catone, sent me letters about once a month. He heard what I was doing. He reached out to me, and he sent me a letter. I was living with my father outside of Boston during that year, and Dr. Catone had that address, and he sent me letters, at least on a monthly basis. I've saved all of them. Dr. Catone has passed away a year ago, the end of July of 2023, and still represents a great deal of inspiration and impact in my life, and he always will. Dr. Marks and I chat on a regular basis. There was a point in time where I addressed them differently than I did in training. Dr. Catone was always Dr. Catone in training. Dr. Marks was always Dr. Marks in training. But after completing those programs, there were times, appropriate times, when Dr. Catone became Guy and Dr. Marks became Bob. And it wasn't with an ounce of disrespect that those changes occurred, but it was in recognition not only of their professional status, but also the friends that they both became to me. And they broke down those barriers. And welcomed that change in how I addressed them. And you know what? That brings you a little bit closer, doesn't it?
Hmm.
And at the right times, I still referred to them as Dr. Catone and Dr. Marks. But there were times when I would address them on a first name basis. I'll also share with you that there are mentors who we have in our careers who didn't train us. One such mentor for me was Dr. Walter Gorelnik from the Mass General Hospital program in Boston. Dr. Gorelnik, as you know, is really the father of the dual degree programs in the United States. He was an educational visionary and created those programs and did it for all the right reasons. He did not possess an MD himself, but he was very supportive of those who wished to and promulgated the careers of those individuals accordingly. At the end of Dr. Gorelnik's life, the Labor Day weekend of 2017, I was in Boston. I heard he had taken ill, and he was admitted for the last time to Mass General Hospital in Boston. I sat with him that weekend. I remember asking him what he expected out of me for the rest of his career because he wasn't eating, he was only drinking water. His list of medications were not being given to him. His pacemaker was shut off, and he was really planning the end of his life. And I sat with him for hours after asking him that question, and he told me what he expected from me. Some of those things I included in my editorial in the Journal of Oral and Maxillofacial Surgery a couple of years ago that I believe was entitled "We All Need Heroes in Our Lives."
Hmm.
And I mentioned my father, and I mentioned Dr. Gorelnik, and I mentioned Sir William Osler. So the point is that we can have mentors who don't train us, and we can have mentors who we don't even know, who we've never met, but are only aware of their exceptional reputations. So there are a lot of different ways to define mentor, but um, I think it's important that we all have one in order to have a career and in order to enjoy the success that we realize.
Yeah. I appreciate the word that you chose to, we need them to have a career. We don't need them to have a job. We need them to have a career.
Right.
And I've, always found that my career has been enriched by so many people who trained me or I've just met through my career.
Yeah.
Uh, and it's been wonderful. I wanted to, I guess, maybe finish up on something here. We're, I guess, an hour into things.
Mm.
But you mentioned doing new things, maybe pushing the envelope, pushing oral surgery, things like Dr. Marks did,
Mm.
you yourself have done. You now have a microvascular fellowship trained faculty member, something new at your institution.
Yeah.
What what challenges have you faced as you have pushed oral surgery forward?
Yeah.
And then maybe what do you see in the future for oral surgery? Where are we going with all of this?
Yeah. These are great questions. One of the things that I always teach my trainees is to be unique. There is a concept in business known as competitive convergence. And what that means is when you hold a skill set that you claim to be worthy of the attention that you receive because you do what you do better than other people who do the same thing. And I don't think that's right. I think that what we do in order to be successful is to provide a unique service in our communities. So competitive convergence, it turns out, is a bad thing because it means that you're going to attempt to compete with someone who does exactly what you do. We see this all over dentistry and medicine. Implantology is a great example of that. And there are those who place implants who believe that they are the person to receive those referrals because they do better than the person who's 100 yards down the road. What you and I have learned in our practice of head and neck surgery is certainly there are instances where we do it better than our competition. And I think a lot of that is our dental training because we're very meticulous clinicians and surgeons. But most importantly, we've carved a niche within head and neck surgery that's unique. And as you mentioned at the outset, you mentioned the expression maxillofacial oncology and reconstructive surgery. And that is the absolute niche that we have created. So some look at what you do, Tom, and what I do is head and neck surgery. And indeed it is. When we do a neck dissection and a parotidectomy and a trach, maybe all three of those procedures in one patient, yes, that's head and neck surgery. But it's also maxillofacial oncology and reconstructive surgery, and it is a unique service that we provide to our patient populations. I think all cancer surgeons love doing benign tumor surgery because, we can more predictably cure those patients, and they're usually younger. They don't have a long list of medical problems and medications that they take, and so they're a better risk for general anesthesia. That is the unique element that we have introduced into, quote, head and neck surgery that we call maxillofacial oncology and reconstructive surgery. So there certainly have been challenges that we have faced over the last 3 decades that I've witnessed in trying to compete with certain specialties. But the way that I think we've done that is to create uniqueness that really belies competitive convergence. So we've created our own niche, and that's what's made you successful and me successful and so many others in our specialty and subspecialty. As we look for the opportunity to be unique, we reject competitive convergence, and we at all times strive to do things better than our competition, but that's not our primary objective. It's rather to really be unique. And this is at the hallmark of our success, I really believe.
Do you think then, I guess what do you see for the future of
Great.
maxillofacial oncology and reconstructive surgery? Is this going to continue to grow as a part of what oral surgery is? I know people talk about separating, but I think we lost Dr. Carlson.
Yeah, he's still on here, but I think he froze up.
Yeah. I thought he was just intently listening to my question.
I'm gonna stop. Oh, here he is.
Oh, there he is. Hey, Dr. Carlson.
Yeah, hey, I'll continue by answering that question, and then Ashley, you can delete what doesn't seem to be where it is. So I'll pause for a second, and then Dr. Schlieve, I'll answer your very good questions. Okay.
Perfect.
In terms of your very good question, Dr. Schlieve, about where we're headed, I would be quick to indicate that we are headed on any path that we so choose. I think our specialty has tremendous human capital, incredible strategic planning, and I think that we need to keep our eyes and ears open in terms of new diagnoses that require our attention. You and I have seen during our careers several new diagnoses. I mean, MRONJ is a great example, and our specialty is really front and center in terms of how to best treat that, as you well know. HPV-related oral and oropharyngeal cancer is another good example that we have embraced, and we have attempted to create treatment strategies and objectively assess our outcomes. In terms of our subspecialty, I think the non-surgical protocols actually are probably worthy of embracing. I think immunotherapy is a tremendous advance in head and neck cancer. I think its benefits are yet to be firmly established. The personalized medicine targeted therapy approach to malignant disease is something that we need to be involved in, and very well-known members of our specialty are, in fact, at this time. So my hope is that the residents who you are training and who I am training at this time will get out of their offices, contribute to maxillofacial trauma teams in their community hospitals locally, and really give back to the specialty and maintain its great reputation as a major surgical enterprise. I don't disparage those who wish to practice in their offices, but I am a little bit concerned with those who retreat to their offices and don't give back clinically and administratively to their local hospitals, whether they be community hospitals or academic centers. I think that is what will keep our name as a specialty in the limelight and continue to keep us highly relevant.
I couldn't agree more. And I guess with that almost very inspirational way to conclude things today, is there anything else, Dr. Carlson, that you would like to share as part of the podcast? Anything that we need to touch on before we tie things up?
No, I think we've had a great dialogue. I really appreciate it. I'll just share something with you as someone who's 8 years into your career and someone whose training I contributed to. Continue to give it your all. You'll be on an elevator at a national meeting or somewhere at some scientific session, and people who you don't know will come up to you and say, "Hello, Dr. Schlieve. It's really good to see you," and they'll introduce themselves to you, and you still won't have any idea who they are, but they'll be one of your groupies. And spend time with them. I know you will, but embrace the opportunity to be known and to continue to be inspirational to people who you don't know, because they're out there, and it's a great opportunity for you. We've talked a lot about mentoring and inspiration and having a career, and there are people who you don't know at this time who are very inspired by what you're doing in the specialty, and they'll approach you, and I know you'll make time for them, and I encourage you to do that every step of the way, because it's just a great opportunity. So I'd like to thank you for this great dialogue. I know that you and I could go on for another 2 hours.
Yep.
We can't do that, but I thank you very much for this wonderful dialogue and an opportunity to spend this time with you. Thank you very much.
You're welcome. Thank you very much, Dr. Carlson, and thank you to Osteoscience for putting things together today.
Yes,
and allowing us to have this dialogue and hopefully inspire some individuals.
Thank you.
To learn more about Osteoscience Foundation, visit osteoscience.org or follow us on Instagram, Facebook, and LinkedIn.